Hello everyone, this is Dr. Suraj. Today we'll be talking about medical termination of pregnancy. This is a very important topic, so let's get going. The first thing that MTP Act came in year 1971. Okay, and the latest amendment came in the year 2022 in the month of September. Okay. Next, coming into the consent. So while we are going to perform MTP, then I have to take consent from the female. Now, if the female is major and mentally sound, in that case, consent from the female is sufficient. So consent only from the female is sufficient. No need to take consent from any guardian. But if the female is mentally not sound or the female is minor, in that case I have to take consent from guardian. So guardian's consent is required in this case. But please do remember, no longer partner's consent or husband's consent are needed. So it is not needed. Next, coming into who can perform the MTP. That means the qualification of the doctor is going to perform this MTP. Any MBBS doctor having the registered medical practitioner having the registration number, any MBBS doctor having experience of conducting 24 MTP at least, okay, of which just 5 MTP he was a primary surgeon. So at least he has assisted at least 25 MTPs and at least 5 should be as a primary surgeon. Next, any RMP having experience of 6 months of house topship or house job in the department of OBG, obstetrics and gynecology, in that case also he or she can perform MTP. Any faculty, that means having diploma, degree, DNB in OBG can also perform MTP. So these are the qualifications of the doctor who can perform MTP. Now coming into the recent changes in MTP. Please do remember, MTP previously it was done till 20 weeks, but now it is extended to 24 weeks. So MTP can be done up to 24 weeks, but if there is fetal anomaly, then it can be extended. Okay, so in case of severe fetal anomaly, the MTP, the upper limit, there is no upper limit. Please remember, there is no upper limit. In case of severe fetal anomaly, there is no upper limit. But please do remember, in that case, whenever you are performing MTP beyond 24 weeks, you cannot just do the MTP. The decision of MTP will be taken by a medical board. So there should be a medical board will be there, and this medical board will be formed by 4 personnel. One from OBG department, another from obviously pediatrics department, another obviously from the radiology department. Okay, and another person will be appointed by the state, so assigned by the state. So these 4 persons, they will be present and the medical board will be formed, and the decision of performing MTP beyond 24 will be taken up by this medical board, and the ultimate decision will be then implemented. Okay, if there is contraceptive failure that led to this MTP to be done, in that case also please do remember the upper limit is 20 weeks, not 24 weeks. MTP done till 20 weeks in case of contraceptive failure. In case of rape, in case of incest, or if that's a mentally unstable person, a mentally unstable female, or is a minor girl, In these all cases, the MTP is done till 24 weeks. Okay, is done till 24 weeks. But please do remember, again I am reiterating the fact that if there is severe fetal anomaly or there is minor, I told you, who or there is minor who actually needs this as an urgent procedure to save the life of the mother, in that case also I have to extend the upper limit, but that decision will be taken by the medical board. So previously it was till 20 weeks, I told you, and the decision of one doctor is sufficient to conduct MTP was sufficient to conduct MTP till 12 weeks. But now single doctor's opinion is sufficient to conduct MTP till 20 weeks, not 12 weeks. And beyond 20 weeks, that means 20 to 24 weeks may you need two doctors' opinion to perform MTP. Okay. So we discussed consent, discussed qualification of the doctor, and discussed the certain changes that had happened in MTP 2022. Let us discuss the various methods of MTP. Now, MTP can be performed in first trimester, MTP can be performed in second trimester. As I told you, MTP is till 24 weeks. So obviously, it includes first trimester abortions and second trimester. So, in MTP in the first trimester can be by means of medical abortions. It can be by means of suction and evacuation. It can be by suction and evacuation, or it may be by manual vacuum aspiration, or menstrual regulation, or menstrual regulation. So this is the thing. These are the four methods by which first trimester MTP done. In case of second trimester, again I have medical abortion, and the surgical method is dilatation and curettage. Okay, dilatation and evacuation. So please remember that the medical abortion that I am talking about in second trimester includes basically prostaglandin analog. Okay, prostaglandin analog. We can use prostaglandin E1 analog. We can use prostaglandin F2 alpha. Can use E2 analog, but mostly E1 analog is used. Okay. So these are the methods of MTP in first trimester as well as in second trimester. So we'll be discussing one by one the MTP. So medical termination of pregnancy in the first trimester, that is the medical abortion. The medical abortion that is done up to 7 weeks. Please do remember. According to WHO, it is extended till 9 weeks. But it is an OPD procedure. But if this medical abortion is done between 7 to 9 weeks, you need to admit the patient. Okay, that is according to WHO. So it's an OPD procedure. What we do basically at day 1, this is OPD procedure. At day 1, I give tablet mifepristone 200 milligram. So tablet mifepristone 200 milligram orally. Okay, then at day 3 I give tablet misoprostol 400 microgram, and that is given either orally or per vaginally or per rectally. Okay, or sublingual, any route can be preferred. So I can give tablet misoprostol 400 microgram. According to WHO, 800 microgram is given. So whatever I am writing in red, they are according to WHO. Whatever writing in blue, that is actually in the India. So what happens? Basically, medical abortion means I am giving certain drugs by which I am inducing the abortion. That is the simplest thing. Okay. So here, after giving tablet misoprostol, the patient will experience bleeding after 2 to 3 days. So bleeding will start. Now, after bleeding, this bleeding will stop. So you see, I have given tablet mifepristone and then misoprostol. After giving misoprostol, the patient will bleed after 2 to 3 days and the bleeding will stop after few days. Now, the stoppage of bleeding indicates that there is completion of abortion. Stoppage of bleeding indicates that is completion of abortion. Okay. So here I don't need any kind of USG to confirm whether the abortion is complete or not. So please do remember that no need of doing USG. No need of doing USG even before starting medical abortion. So here I will ask the mother to come at day 15 and then I'll check whether the bleeding is actually stopped or not, and then I'll confirm yes, the medical termination of pregnancy is complete via medical abortion. Again, I'm repeating this thing that this medical abortion is done till 7 weeks. It's an OPD procedure where we give tablet mifepristone 200 milligram orally at day 1. Then at day 3, tablet misoprostol 400 microgram is given. Okay. Now, after starting the patient on misoprostol, after 2 to 3 days, the patient will experience bleeding and this bleeding will stop after few days. Stoppage of bleeding indicates completion of abortion process. Then I'll ask the mother to come at day 15 and I'll ensure whether the bleeding is actually stopped or not. If the bleeding is stopped, then I can confirm it. But I told you that USG not required in these cases because I can just assure that whether abortion is complete by just doing a PB examination only. So if they ask you till 7 weeks, which is the which is the best method for MTP, please remember it is the medical abortion. Okay, 2 changes in WHO, it is 7 to 9 weeks. Till 9 weeks medical abortion can be done and the misoprostol dose is 800 microgram. Please do remember here that though according to WHO is 9 weeks, but if they ask you that what is the best method of doing MTP between 7 to 12 weeks, it is suction and evacuation. Okay, suction and evacuation. Now, suction and evacuation is an IPD procedure. It's an IPD procedure. You have to admit the patient, and in the IPD procedure when you admit the patient will be in the lithotomy position. While you doing, the patient will be in the lithotomy position and you give paracervical block. Paracervical block is given at anywhere except 3 o'clock and 9 o'clock position, because in this 3 o'clock and 9 o'clock position there is descending cervical artery is there, and if you go and inject the anesthetic agent there, it will actually go to the systemic circulation, so that will cause side effect, and that's why 3 o'clock and 9 o'clock is not chosen. Paracervical block is given any other than 3 o'clock and 9 o'clock position. Okay, so in case of suction and evacuation, and also in case of dilatation and evacuation procedure, this paracervical block is given, and this 3 o'clock and 9 o'clock positions are avoided due to presence of this descending cervical artery. Okay, now while we are doing suctioning, so that means I am generating some pressure. They'll ask you what is the pressure generated. Please do remember the pressure generated is around 600 mmHg. That's a negative pressure, obviously. Negative pressure. Okay. Next, I am coming into the procedure of suction and evacuation in a very short manner. So before I am taking the patient for suction and evacuation, first thing I have taken consent. Okay, now after the consent, please remember, you have to ask the mother to empty the bladder. So empty the bladder. If it could not be done, then just put a Foley's catheter inside and evacuate the bladder. That is very important. And after that, you have to do a per vaginal and per specular examination. This is done to assess the size and position of the uterus even before performing this MTP, because I need to know the position of the uterus and the size of the uterus for a complete suction and evacuation to be done. The instruments required for that, number 1 is Sims non-self-retaining posterior vaginal wall speculum. This one. This is, in short, I am just writing Sims speculum. Sims speculum. So you can see this is non-self-retaining, means you have to hold it. So assistant is required. Next, it is posterior vaginal wall retractor. Next is anterior vaginal wall retractor. So you need another instrument to actually retract the anterior wall of the vagina. So vaginal anterior and posterior wall are collapsed like that. So what you have to do, you have to put the Sims speculum here and you have to retract it, and the anterior vaginal wall retractor you have to put here and you have to retract it, so that this both anterior and posterior, this vaginal wall gets retracted and you can see the cervix. So this is anterior vaginal wall retractor. You can see these serrations are there also, and there is a gap, and the both sides are similar. Next, I have to use a valsalum. This is the valsalum. This is used to actually hold the cervical lip, the anterior lip of the cervix. You have to hold it and retract it. Next, you have to use an uterine sound. Please remember, this is the uterine sound. What is the use of uterine sound? Uterine sound, you can see, this is the uterine sound. It is used, it acts as a fast dilator. Please remember, fast dilator. That means, I told you, you have to know the size of the uterus and position of the uterus before performing MTP. So what I have done, I have retracted the posterior vaginal wall, I have retracted the anterior vaginal wall, then I have retracted the cervical lip, the cervix, lip of the cervix is retracted by using a valsalum. So what I can see is the internal os. Now this internal os is not dilated. Okay, so what you have to first do, you have to use a uterine sound, and this uterine sound is gradually inserted through that internal os. Its diameter is so less, and this will guide you according to the uterine position. It will also give you a length assumption. It will also give you a length assumption. Suppose you inserted this much, so this much will be the uterine size, and also the curve will guide you the version of the uterus, whether it is retroverted or anteverted, like that. So uterine sound can help you. So it acts as a fast dilator, first thing. Okay, that means we are just using it for assessing the uterine size and uterine position, but as we are inserting it through the internal os, so it will act as a fast dilator. Next, it will help you to assess the uterine size and position, very important. I think you understand it. Okay, then after I have assessed the uterine size and position, what I will be using? I will be using Hager's dilator. This is Hager's dilator. Hager's dilator. So you can see that Hager's dilator having different diameters in both the side. Okay, so I'll put the narrowest one. So I'll insert the narrowest one, and then gradually, first I'll insert this one, then gradually insert this side, then I'll gradually insert this side, and then gradually insert. So we are gradually inserting an increasing order of diameter to gradually dilate the cervix, the internal os. We are not just putting this larger diameter that can cause the rupture of the internal os. So gradually I will be dilating the internal os by putting increasing order of the Hager's dilator. Now after attaining the appropriate cervical dilation, then I have to use Carman's cannula. That is very important. Carman's cannula. So please do remember Carman's cannula, they are plastic cannulas. I'll be showing you the image. Plastic cannulas there. And what we do, this plastic cannula ke saath we actually attach the suction machine. So the suction machine is attached with this plastic cannula inside, and this suction catheter is attached. Suction catheter is attached. So suction catheter is attached, and with this suction catheter I will be attaching the suction machine. So when the suction machine will be on, it will suck and it will create a pressure. I told you 600 mmHg, and the plastic cannula, this is the Carman's cannula. You can see this is the Carman's cannula. So this side I will be attaching the suction catheter, and that suction catheter will be attached to suction machine, and here you can see the opening. So it will suck the content and this content will go. Okay, why this is very important, I will be discussing some clinical aspects regarding Carman's cannula. Next thing about Carman's cannula is the size. So remember, Carman's cannula, what size you have to use. Okay, please remember the period of gestation will tell you the size of Carman's cannula. Supposing you are performing MTP in a 16 weeks female, so the Carman's cannula size will correspond to that, like 16. Okay, so 16. So like the 10 weeks POC, so size will be 10. Then after completion of this suction and evacuation, you have to go for blunt curettage, that is called check curettage by blunt forceps. So again I am just revising the process. It's a very short discussion, but I want to give you a briefing. I want to give you all the things here so that you cannot forget it. So first you will take consent, then empty the bladder, or if you put a Foley's catheter and evacuate the bladder, do pervaginal perspecular examination, and after doing that you have to assess the size and position of the uterus. So these are the instrument: posterior-vaginal wall retractor, anterior-vaginal wall retractor, then cervical lip is held by valsalum. Then you use a uterine sound to assess the position and size, which will also act as a first dilator. Then you use successive increasing diameters of Hager's dilator. We will be inserted inside the internal os, and will be inserting it to dilate the internal os of the cervix. And then after achieving appropriate dilation, you will be using Carman's cannula, which will be the size of which will be corresponding to the period of gestation. Okay, and then you will attach the suction catheter, and then suction machine will be switched on. It will suck the contents. Now till what time you will suck? Till what time the suction and evacuation will go on? So there is something known as end point of suction. So please remember, you are suctioning, but at a time you feel that there is decreased bleeding. So the bleeding is decreased, the blood loss is decreased, no more blood is coming out through this suction catheter. Or you see that air bubble is coming, air bubbles are coming. That means your suction is complete, no more content is there, so air is coming. Or there may be gripping sensation, that means your Carman's cannula, that means your suction is complete, now your uterine myometrium is now gripping the Carman's cannula, or there will be grating sensations. So when these things, you feel that suction and evacuation process is complete, and that points towards the end point of suction. Now once there is end point of suction, you have to do, I just told you, a check curettage. This is known as check curettage. You have to do a check curettage, okay, by a blunt forceps. In case of molar pregnancy, we use sharp forceps for check curettage, and in case of SE and DE, we use blunt forceps for check curettage. So this slide is very important. Okay, This slide is very important. Next we are going to discuss, this is the S&E in case of rural setting. What you will do in rural areas, you don't have electricity. Okay, you also cannot put on the suction machine on, so there is no electricity, no suction machine. So in that case, the suction and evacuation will be replaced by an alternate method called MVA, that is manual vacuum aspiration. I just told you previously. Okay, see here. So manual vacuum aspiration is actually done by this syringe, that is called manual vacuum aspiration syringe. The volume of the syringe is 60 milliliter, and here the pressure generated is 660 mmHg pressure is generated. So you can see two pinch bulbs there, two pinch bulbs are there. You press on this pinch bulbs and then you suck it, or you actually this plunger is then moved in and out, so to activate the suctioning. So here you are manually suctioning. Okay, there is no suction machine is on, no electricity is required. You are just pumping the plunger in and out by pressing these pinch bulbs, and you are doing suction and evacuation here. So this is a manual vacuum aspiration, not suction and evacuation. This is a manual vacuum aspiration. Okay, now the similar looking syringe is also there, that is known as menstrual regulation syringe. Okay, and there the content is there the volume is 50 ml, having one pinch bulb. But remember, in case of MVA syringe, one pinch bulb may be present. Okay, so this is all about. So I told you that while doing Karman's cannula, you are doing suctioning, there may be something, or while you are putting Hager's dilator, there might be some complications, because this is a blind procedure and you are inserting those instruments blindly. So one very important thing can happen is the perforation. So how to tackle this situation? Supposing there is perforation while you are putting Hager's dilator. Now, while you are putting Hager's dilator or uterine sound, please do remember, uterine sound तो diameter बहुत ही छोटा, Hager's dilator and uterine sound, and you perforate the uterus. Okay, you are seeing that more than the length of the uterus is the instrument is actually pushed inside. So in that case, what you will do, you will stop the procedure and you have to wait. Stop the procedure and wait. Stop the procedure and monitor the vitals. That is very, very important. So stop the procedures and monitor the vitals. That is called wait and watch procedure. You are gonna follow wait and watch procedure as the Hager's dilator or uterine sound. If perforation happens with these two instruments, then we'll stop the procedure and we'll monitor the vitals. Okay. Now coming into, supposing while doing suctioning, my Karman's cannula perforates the uterus. So please remember, this is not the same case. Why? Because this Karman's cannula, I told you, it is attached with what? Suction catheter and suction machine. That means continuously the negative pressure is present inside the Karman's cannula. So here I cannot just stop the procedure and take out the Karman's cannula. Okay, so here please do remember, stop the procedure and remove the instruments. Okay, but here if while doing suctioning, If there is perforation, again you have to stop the procedure. Stop the procedure. That means you will first switch off the suction machine. You will first switch off the suction machine, not you, the lab assistant, the OT assistant. Okay, so switch off the suction machine and don't proceed further. You are not going to do suctioning again, so don't proceed further. Okay, then what will you do? Will you remove the Karman's cannula? No, do not take out Karman's cannula. This is the most important thing. You do not take out the Karman's cannula. Okay, just switch off the suction machine and don't proceed further. Okay, monitor the vitals and don't take out the Karman's cannula. In this, you are going to go for an immediate laparoscopy. You have to go for immediate laparoscopy. Okay, so this is very important while you are doing immediate laparoscopy. Now, why this instrument is not taken out? Because please remember, this instrument during suction, if the perforation had happened, I don't know whether any part of intestine or whether any part of omentum or other structure that is sucked inside this cannula. So if I try to remove, I might further injure the gut or omentum, and that can aggravate the injury. So wherever my Karman's cannula is, whatever structures it sucked in, so I am not going to go further. I will be just switching off the suction machine. I will be staying there and preparing the patient for laparoscopy. In that case, it also gives some importance, like while doing laparoscopy, I don't have to blindly, search where actually the perforation happened, because if I put the Karman's cannula in the same position, it will also give a clue that yes, this side the perforation happened. I have to look and operate on that side. So that's why, so it will guide also during this immediate laparoscopy while we'll be performing that. So you have to go for this. So perforation is a very important. If it is happened due to Hager's or uterine sound, just monitor vitals and remove the instrument. If it is during suctioning by Karman's cannula, then please don't proceed and don't take out the instrument and take the patient for immediate laparoscopy. Now let us talk about the abortion technique in second trimester. So as I told you, second trimester abortion, again you have to admit this patient, and you can perform by two ways. One is medical abortion, which is also known as mini laparotomy. Mini labor. So it is also known as mini labor because you are inducing the labor by giving some medications like progesterone. I told you those things. Okay, or surgical, that is dilation and evacuation. So mini labor is medical abortion and surgical is DNA. Now mini labor can be done by four things. One, I told you, by giving progesterone. Okay, next can be EM, that is extra amniotic ethacridine. Extra amniotic ethacridine. Or it can be by intraamniotic saline, or it can be by oxytocin. These are not used. Okay, what is used in medical abortion second trimester is prostaglandins. So let us discuss here. See, extraamniotic ethacridine, intraamniotic saline and oxytocin, these are not used. Okay, what is extraamniotic ethacridine? Just telling you, we use 0.1% of ethacridine, and what we do actually, we put a Foley's catheter inside the vagina, not urethra, it's inside the vagina. So Foley's catheter Foley's catheter is put inside the vagina. Where? It is actually put inside the uterus. Okay, not vagina. It is inside the uterus, between the membranes and uterus. So if you see, this is the uterine wall. This is the uterine, not needed actually. Not needed actually. This is the uterine wall, and you see this is the membranes. This is the membranes. Okay. What we put? We put the Foley's catheter here. We put the Foley's catheter here, and with the Foley's catheter I give 0.1% ethacridine. This is given through the Foley's catheter. So you'll go in between the membrane and the uterus, and this drug will be sprayed here. That leads to what? Separation of the membrane from the uterus. And whenever there is separation of the membranes from the uterus, this separation of membrane from the uterus will actually release prostaglandin. So ultimately, if you see, that is prostaglandin. So why to put Foley's and then give ethacridine, then separating the membranes and then prostaglandin? Rather just keep prostaglandin. Okay, so ultimately separation of membrane will release prostaglandins, and that will induce the labor. So uterine contraction will happen, and that will cause separation, abortion. So we are not using this anymore. That's why we are just using prostaglandins. So I told you prostaglandins may be PGE1 analog, and that I told you is a misoprostol. So what we use generally, a dose of 400 microgram. Okay, that misoprostol is used, and that is given 4 hourly. Okay, it is used, misoprostol is used, and here it is used parvaginally. So where we used misoprostol? Yes, we have told you that misoprostol is also used in medical abortion in first trimester, but there it is not misoprostol. First I have to give at day 1 mifepristone 200 milligram, and then at day 3 I was giving misoprostol. But here there is no role of mifepristone. Please remember, in second trimester I am not giving mifepristone, I am just giving misoprostol, and OV parvaginally, that is given parvaginally. Okay, this is prostaglandin E1 analog. Yes, we can also use carboprost. Carboprost can be used, that is F2 alpha analog. Also we can use dinoprostone, which is E2 analog. Okay, other things I told you, these things are there, not used. The surgical one is dilation and evacuation. I think you remember the table. Okay, that table where I discussed the second trimester mein medical, mostly prostaglandins, and surgical one is D and E. So we'll be ending our discussion just by saying some facts regarding dilatation and evacuation. Okay, so again see here, it is similar till the internal os dilatation. Okay, here we are not using Kerman's cannula because this is dilatation and evacuation. We are going to evacuate the contents by using sponge holding forceps. You can see this is a sponge holding forceps, or by using ovum forceps. This is ovum forceps. Okay, now the difference is that in sponge holding forceps you can see there is ratchet lock is there. Okay, and also you can see the opening. Okay, now here sponge holding forceps, you can see there is spoon shaped steep, spoon shaped, and there is no ratchet lock. Ratchet lock is not present in ovum forceps and Shitley's forceps. These are the two forceps where ratchet lock is not there. Okay, this and Shitley's forceps. These are the two forceps where we don't have ratchet lock. So this is done, and again check curettage is done. So D and E procedure is same like I told you here, only suction and evacuation, but we are not using this Kerman's cannula, rather we are putting the sponge holding or ovum forceps, and then we are scraping. Okay, and the end point last we have to do blunt forceps, that is for checked curettage, whether any content content has remained or not. We have to check that. Okay, I told you molar pregnancy I have to go for sharp curettage. Here we have to go for blunt curettage. Okay, so that is all about medical termination of pregnancy. Okay, so here also we are using paracervical block, I told you, and lithotomy position it has to be done. So that is all. Thank you.